Hello everyone. Now I will discuss question of respiratory system. So we got a 32-year-old man who come to you for a routine health checkup, and he has a 5-year history of bronchial asthma. His age is 32 years, for which he uses albuterol inhaler during the day an average of twice a week. It's a very important point. In addition to his asthma, he wake up from the sleep approximately 3 to 4 times per month. This is again a very important point. The patient is allergic to dust, mite and ragweed. That means a type of allergic asthma. But he has no other medical issues. And family history is significant for asthma in his grandfather. Vital signs are normal at the moment. Lung auscultation indicate normal breath sound without wheezing. That means vital sign normal means respiratory rate is normal, and this lung finding indicate normal. That means by and large he has no respiratory problem, although he's a known case of asthma, and we can conclude as of now he's having allergic asthma but stable at the moment. What is the most appropriate next step in the management of this patient? Answer is add inhaled corticosteroids. Why this is the answer? Okay. Well, in this patient history of intermittent asthma, managed as a need with short-acting SABA, that is albuterol. But this is not enough. We got to know much more to understand this. Well, the need to initiate control medication therapy, the level of control therapy is evaluated by categorizing symptom into 1 to 4 level. This is a basic concept, the basic principle of management of asthma. Unless we understand this, then we will not be able to understand why in this case we are going to add steroids. For the reason, although patients seem to be clinically all right. Let us see. So we classify into 4 categories. One is intermittent. Next is persistent, moderate persistent and severe persistent. So if you say again to make easy, it is intermittent, then it is persistent but mild, moderate and severe. I hope things are simpler for you. Well, let's learn the basic concept on this classification is based. So asthma severity, first is intermittent. In this, frequency of the symptom or use of SABA, short-acting beta agonist, less than 2 days a week, less than night awakening, less than or equal to 2 times a month, and we indicated therapy initiation is step 1. Well, now mild persistent, it is more than 2 days a week, but not daily. Previously was less than 2. Okay, or equal to 2. This is more than 2 days a week, 3 to 4 times a month, step 2. Here it was less than 2 or equal to 2. Moderate daily, more than 1 time a week but not nightly, step 3. And finally severe persistent throughout the day, 4 to 7 times a week, that will almost you can say every alternate day or daily, step 4 or 5. This is how we really classify the severity, and it is that now your concepts are clear that what we did in this particular slide. So now we talk about, well, and now our patient requiring his albuterol inhaler 2 days per week, which suggests a good control, and that we can see with the patient examination finding and the respiratory rate. He has been having 3 to 4 night times awakening per month, which indicate he undertreated with as needed by. Point to be noted in this case, daytime problem is not much, but problem is at the night, 3 to 4 times. Okay, so 3 to 4 times means, so for his current level of symptom, that he now meet the criteria of a mild persistent asthma. Okay, why? Because of this reason, 3 to 4 times. Agreed? So this warrants a step up in therapy with the addition of low dose inhaled corticosteroid step 2. Once patient begins asthma control therapy, ICS, they are evaluated based on symptomatic assessment of asthma control. Definitely, we are going to assess how the patient is going on. Patient whose condition remain well controlled on the same therapy for 3 months should be considered for a step down in the medication management. That means, like in this case, we say the patient is in mild persistent. We add into next step, we add ICS, inhaled corticosteroids, which is the next step in the management. And we continue for 3 months. When the patient may or continue for 3-month therapy, then we can think of going down back to step. Well, patient with very poorly controlled symptom, medication should be increased by 1 to 2 steps. With a short course of oral prednisolone should be considered. That means we are managing the mild persistent also, still not, then you go to step up. That means we all go by step up treatment. Now, this option B, add ipratropium inhaler. Ipratropium is a short-acting anticholinergic drug. It has a slower onset of action and achieve less bronchodilation in asthmatic patient than a SABA. In fact, this is a very good drug, has a good effect in COPD patient, but it's not a very good drug for asthma. And of course, that definitely it's a SABA, that is short-acting beta agonist, is far better than ipratropium, which is an anticholinergic drug. So, as ipratropium does play a role in the management of COPD, but not indicated in asthma management, except in rare circumstances. So, this automatically rules out because this is not a drug primarily for asthma; it's primarily drug for COPD. Now, what about LABA, long-acting beta-2 agonist? Due to evidence of increased mortality as well as treatment failure in asthmatic patient, LABA monotherapy. Point to be noted. In addition, LABA indicated only in combination with ICS. The point to be noted. Okay, so first we give ICS like that we already have given. The LABA is given after if patient not controlled with ICS. What about oral prednisolone? Short course of oral prednisolone are indicated in acute asthma exacerbation and cases of very poorly controlled symptom, then we can add. Rather, you can say even ICS, inhaled corticosteroid, are not working, then we can give oral steroid short course, or patient has come with acute attack, then we can give steroid. Now, one thing I like to add to you, we are talking about oral. Now, in acute attack, we can give intravenous, rather it is more commonly given. But one thing at the back of the mind you should know, both oral and IV are equally effective in acute asthma, but by all practical, you can say management, people prefer to go by IV route. But however, you can very well give oral also. But we cannot use steroid for a long time. The chronic use of steroid, maybe oral or IV, they can have a lot of adverse effect. Now, stop the video. I have a question for you. Write down the answer. What are the metabolic and cardiovascular side effects of chronic use of steroids? Quickly write down the answer in your copy. Stop the video. Well, the answer is it leads to hyperglycemia. That means it can worsen diabetes or it can start new diabetes, drug-induced diabetes. And as far as cardiovascular concerned, they can lead to hypertension. Okay, so there are two big things. Both are very dangerous diseases. So they can lead to these two problems. And of course, they can lead to hypocalcemia also. Well, what about option E? Continue current medication. Therapy should not be appropriate as the patient's symptoms are uncontrolled and step up is needed. And patient has a problem in the night, although day is not a problem. So we need to step up. So golden line to remember, mild persistent asthma is characterized by symptom more than 2 days per week or 3 to 4 nightly awakening. Any one of them. In our patient, the problem was for the night awakening per month. Patient will require a daily control of medication, inhaled corticosteroid, ICS, in addition to SABA short-acting beta-2 agonist. Thank you very much.